Welcome back. Today we will be dealing with how to approach to a patient with dyspnea. As you all know, dyspnea is an unpleasant or undue awareness of one's own breathing, and the main systems involved in dyspnea could be cardiovascular system and respiratory system, although neurological, neuromuscular and metabolic causes can also produce dyspnea. So, whenever you see a patient with dyspnea, it is important that you grade the dyspnea according to either the New York Heart Association classification, and that is predominantly used for symptoms which are suggestive of a cardiovascular involvement. Like if you think the patient is having a cardiovascular problem, you go for the NYHA classification of dyspnea from class 1 to class 4. Or if you think that predominantly the dyspnea could be caused due to respiratory system, you go for the modified medical research council grading of breathlessness from grade 0 to grade 4. So that will give an idea to the listener regarding the degree of breathlessness, how fast it is worsening, etc., without much explanation. So whenever there is dyspnea, I told you the main systems involved are the pulmonary and the cardiovascular system. So what are the common pulmonary causes? It could be airway obstruction in the form of a chronic obstructive pulmonary disease with acute exacerbation, bronchial asthma, any other cause for airway obstruction. It could be parenchymal diseases like interstitial lung disease or pneumonia. Chest wall diseases can produce dyspnea. Among the cardiovascular causes, it is predominantly the left heart involvement that produces dyspnea, either due to coronary artery disease, a myocardial disease, valvular heart disease, or pericardial disease. The left heart involvement predominantly produces dyspnea. Now, other conditions which produce dyspnea include anemia, metabolic causes, neurological causes, because it is the brainstem that contains the centers that control the respiration. So brainstem involvement can also produce dyspnea. So I will introduce you to certain terms like orthopnea, which is dyspnea on lying flat, which is very common in any acutely ill patient, predominantly seen in left heart failure, but could be a part of COPD, bronchial asthma, ILDs, etc. The opposite of orthopnea is platypnea, where the dyspnea is on upright position. Rarely seen this condition, even though theoretically we say about it. Can be seen in left atrial myxoma, where the myxoma, the position of the tumor changes according to whether the patient is lying down or sitting up. In hepatopulmonary syndrome, the explanation is there is opening up of pulmonary AV channels on sitting up, and so there is a ventilation, there is more of perfusion but less of ventilation, and a ventilation perfusion mismatch on sitting up. Now trypopnea is shortness of breath experienced while lying on one side. Usually breathlessness worsens on lying on the affected side, because whenever the patient lies on the involved side, due to ventilation perfusion mismatch, because when the patient lies on the involved side, there is increased perfusion because of gravity, while ventilation is decreased because the lung is diseased. So the dyspnea worsens. So that is trypopnea. Now you have all heard about paroxysmal nocturnal dyspnea, which is a marker of left ventricular disease, where the patient goes to sleep, and in the early hours of sleep itself the patient gets up with breathlessness, goes to the windows, open up, get fresh air, and sometimes the breathlessness subsides. So there are many mechanisms or explaining the paroxysmal nocturnal dyspnea. Either it could be, these are the mechanisms, it could be due to gradual accumulation of alveolar fluid during sleep, due to redistribution of fluid to the lung due to increased venous return, or it could be that there is the diaphragm, etc., moves up on lying down, and there is increased left atrial pressure. Also at night there is a fall in PaO2, so there is a stimulation of the respiratory centers. All these are explanations for PND, and you have to distinguish the paroxysmal nocturnal dyspnea from the acute exacerbations of COPD and bronchial asthma, which occurs predominantly late night, and the history will be different in both. The one would be having a history of cardiac disease, cardinal symptoms of cardiac disease in the form of palpitation, chest pain, while the other would be having recurrent episodes of breathlessness, inhalation intake, etc. Examination also might yield crepitations in paroxysmal nocturnal dyspnea, basal crepitations, while in bronchial asthma it would be predominantly rhonchi. Now, whenever the patient presents with dyspnea, you have to classify it whether it is acute or a chronic or subacutely progressive dyspnea. The acute dyspnea means dyspnea which develops within hours. So, one of the important causes for acute dyspnea is pulmonary edema, where the dyspnea develops within minutes to hours. So so if it is pulmonary edema, the patient would be having chest pain, palpitation, orthopnea, etc. as associated complaints. Now, massive pulmonary embolism can present as acute onset dyspnea, where the patient would have predisposing conditions like maybe the patient is pregnant or the patient is bedridden for a long time or after surgery, or the patient is having an acute illness which makes the patient confined to bed without moving the limbs, or the patient has a malignancy which produces hypercoagulable states. These are the common conditions that predispose to acute pulmonary embolism, but rarely in certain prothrombotic conditions without any of these predisposing things also the patient might develop a pulmonary embolism. Now, if the patient develops dyspnea, a COPD patient developing severe acute dyspnea after a bout of cough with sinus, etc., you think of the possibility of pneumothorax. Also, acute exacerbations of bronchial asthma, COPD also can produce acute breathlessness. Now, if it is chronic breathlessness, again the similar conditions like COPD, interstitial lung disease, chronic heart failure, etc., will produce a long duration breathlessness which has acute exacerbations and remissions. So, whenever you see a patient with dyspnea, ask about the onset, whether it is acute, subacute, or chronic. The duration of symptoms are important. What precipitates, like an exercise, etc., precipitating might suggest a pulmonary edema. A bedridden patient developing dyspnea might suggest a pulmonary embolism. Exposure to cold or dust exacerbating dyspnea could be due to bronchial asthma, COPD, etc. Associated symptoms are important. What effect it has on daily activities you have to ask for, and also the past medical history. So that gives you an idea regarding how to approach a patient with dyspnea. Thank you.